Hey guys, and welcome to episode 142 of the OCDstories.com podcast. Now, in this episode, I interviewed Ashley Annestedt. Ashley is a therapist based in the States. We talk about many topics, wide-ranging in this one. We talk about what it means to be treatment ready, advice for starting ERP. We talk about when someone starts to reduce compulsions and they get a bit more time back. How they deal with the sort of shame and guilt that some people feel about the time they feel they've lost because of OCD and the missed opportunities, how they kind of deal with some of those more troubling emotions they may find with the increased time they have. She gives a great answer, so hopefully that helps you if you find yourself in that place. We also talk about acceptance commitment therapy when she brings it in with some of her clients. We talk about sleep quality and how this can impact OCD and tips for improving sleep quality. I ask her about better ways of living with uncertainty. With OCD, sometimes it's hard to live in those uncertain places. So, hopefully her answer helps you. And then I ask her about self-care strategies, things that, help her, things that lift her up, that just kind of boost her well-being. So hopefully some of those ideas inspire you. Without further ado, here is Ashley. On the podcast today, I have Ashley Annestedt. Ashley is a licensed clinical social worker specializing in OCD, anxiety, and neurobehavioral disorders. Ashley is licensed to provide therapy in 6 US states and working on a 7th. Welcome to the show, Ashley.
Thanks, Stu. Thanks for having me.
It's good to have you on, and thanks to Chrissy for putting your name forward.
Yeah, absolutely. I think I told you via email that so many of my patients listen to this, so it's cool to be on the flip side of it.
Oh, cool. No, I appreciate it.
Yeah.
Okay, cool. So my first question is, I always ask therapists kind of why they started treating OCD, I guess.
Well, the short of it is, it's quite a long story, but I spent a lot of time working in East Africa for a nonprofit, whose primary focus was physical aid and safety. And while there, just kind of noticing the mental health needs were, not being ignored, but when you don't know where your next meal is coming from or the safety of your village, mental health isn't necessarily the priority. So that's what really drove me into mental health as a whole. And then after that in graduate school, my graduate professor, who was truly a mentor to me, Dr. David Dia, really had a specialty and focus in OCD. If I can be quite honest, I never thought I would do therapy. I envisioned therapy as somebody laying on a couch talking about their feelings or being hypnotized, the stereotypes that are so inaccurate, as I now know, but that's what I thought it was. So I really had no interest in it. I thought I would go back to Africa and work there on a larger scale. But once I started, kind of practicing under him and learning more, I was instantly hooked. Because it is such, gratifying work. Yeah.
And is it kind of the results-orientated side of it that made it so gratifying?
Absolutely. I mean, I guess that may be a kind of a selfish answer, that you get to see people get well rather quickly and get back to living life according to what they value and what's important to them. But for me as a therapist to, be able to see somebody have such improvements in, months rather than 25 years per se. Yeah. It's very rewarding.
Absolutely. No, it makes sense. You've got to see progress in your job to get enjoyment a lot of the time.
Absolutely. Yeah. And once I knew you didn't have to lay on a couch and hypnotize people, it was all the better.
Yeah. Okay, cool. So maybe an obvious question, but why get licensed in so many states?
The answer is twofold. First being just to fill a really significant void. Here in the States, many states throughout the United States do not have a clinician that's truly trained in treating OCD. So they're, without that. So that was my first motivation to be able to fill those voids for patients. And, on the flip side, again, it may be a selfish response, but it's also a good business decision, to be able to fill that void for patients as well.
No, absolutely. And is that over the internet you do those sessions, or you jump on a low-cost airline and do the session?
No, everything's done via a secure server called VC that functions very similar to Skype. So we're, face-to-face versus couch-to-couch, I like to say.
Yeah. Cool. And how have you found the two types of sessions? Do they differ much in terms of in-person versus via, I'm going to say Skype because I keep forgetting the
Yeah,
program.
that's fine.
Yeah.
I don't think clinically in terms of outcomes they differ all that much. Just anecdotally for my practice, I do find the success rate to be higher via online means. I don't have any research to back that up, but if you can just think, the cancellation rates are far lower because all you have to do is press a button and sit on your couch rather than sit in an hour's worth of traffic. And then I also find that the sort of ice is broken a little earlier because the stigma's not there. They're not having to go to a strange office. They're in their pajamas, potentially on their couch or elsewhere. So it's a lot easier for me, and I think I have hopefully for them as well. I feel the trust is established a little bit quicker.
Yeah, that makes sense. And I guess it's also they're more triggered in the home environment than they will be, say, in your office.
Absolutely. Yeah. So the context of exposures can be much richer in their natural environment, treating OCD where it lives, I like to say, rather than, four white walls and a couch.
Yeah. No, that's refreshing to hear, because obviously a lot of the press are not focused on OCD, but whenever they talk about teletherapy, they always knock it.
Absolutely.
And it makes sense. As soon as something new comes in, people do bash it for various reasons. But it's good to hear that other take of the benefits of it as well. So reason I guess I'm saying that is just if it's someone's only option, that they shouldn't be disheartened by that. It's still a good method of therapy.
Absolutely. And I have people that are, within 10 minutes of my, brick and mortar office, if you will, but we'll still have them do an online session, because if we can add some context to the exposures, that's usually going to, produce a more beneficial scenario. So for example, I don't know, my favorite example is perhaps a new mom that has pedophilic OCD, and the most vulnerable time for her is, giving her baby a bath. Well, naturally, I probably am not going to try to have her bring the baby to my office and bring the bathtub and everything else. So if we can do that in her natural environment, she brings her little laptop in the bathtub or the bathroom with her, and we can conduct that in her natural space, all the better.
Absolutely. That was a good example. And I noticed on your website you talk, which I really liked, you talked about being treatment ready. You said there's one thing needing treatment, and then there's another thing being treatment ready.
Absolutely.
What do you mean by that, and why is it important?
I think, needing treatment often comes from perhaps the push or pull from other providers, from family, and perhaps the individual is not really treatment ready. So they're contacting me or another clinician just because they've been, quote unquote, told to, and they're not really ready for what treatment entails. Whereas treatment ready, they're really motivated. Treatment's going to be kind of a high priority on their list. Not to say it should be somebody's number one. You still have to feed your family and go to work and all those good things. But if it's number 12 or 13, it's probably not going to really produce the best outcomes.
Yeah, makes sense. And if someone comes to you and you feel they're not necessarily in that place yet, is that something you kind of have that conversation, whether to see it's come back at a later date or try and, I guess, motivate them and get them to push it up that list?
Yeah, it can be both. I try to educate interested patients as much as possible as to what treatment entails with regards to time and emotional energy, so they can make a good choice as to if they can fit it in their lives. If they think they can, then I think those first few sessions are about exploring that. But I'm pretty candid and just kind of an open book. So if after those first few sessions somebody is still really dragging their feet and it doesn't look like we're going to have any movement, I'm really honest to say, maybe now's not the best time, and we can revisit this. The relationship's already established and already here. So, come back in 6 months, a year, whenever you feel like you're ready.
Yeah, absolutely. And I guess you're also saving their money, so you're...
Absolutely.
Yeah.
And that's one of the first things I say, which is a huge motivator for people. Let's save your finances right now if you don't think that you're ready.
Yeah, absolutely. Okay, and obviously ERP is one of the core treatments you do for OCD. Obviously, you kind of explain it to them, what it is, why it works, X, Y, and Z. Is there anything that particularly you share with them that kind of get them to understand it or motivate them, or yeah, I guess, are there any kind of words that may be different to another clinician's?
Sure. I use a lot of analogies, just sort of real world analogies to help them understand what the process can feel like. So, do you remember going to your first day of, whatever grade it is, 5th grade, 6th grade? You were really nervous, but day after day, when you continue to go, you either see a decrease in anxiety or an increase in your tolerance of the anxiety, kind of whatever way you look at it, habituation or otherwise. So I explain it with real world examples, typically to help them understand, what it's going to look like for them.
Yeah. Okay. Excellent. And so, some people can get, I use the word complacent during treatment when they start to see progress. I think it's a natural human reaction to kind of take the foot off the gas. Is this something you've noticed, and what kind of conversations do you have with your client when that happens?
Yes, I would say I noticed that with, probably the vast majority of clients that I see, because it is just such a natural instinct. It's like once you've lost 48 pounds, if your goal is 50, it's really hard to lose those last two.
Yeah.
So I kind of give the same example with them. If you're looking at OCD symptoms as percentages, that last 10%, 20% can really be the hardest to treat, because now you're living the life that you want. The symptoms are pretty manageable, but I really still push people to, let's treat it all, let's address it all, because your success rate long term is going to be, increased and more solid than kind of putting treatment on the back burner right now.
Yeah, it makes sense. And I guess it's kind of like lifting weights, for example, or running. You can make in the first year huge improvements, and then but year 2, 3, 4, and 5, the amount you improve decreases. So it's almost like you're getting less bang for your buck, and maybe that's the natural.
That's a good point.
Okay, cool. So another question I get asked a lot is, or I see around forums and stuff, is as people start to reduce their compulsions, they get more of their time back. This kind of not knowing what to do with it, which is kind of living a valued life, filling that time with meaningful activities. But the other part is starting to feel, I don't say guilt, but like regret about what, the opportunities they've lost, the things they've missed because of OCD. Does that come up for you? And I guess, how do you kind of address that when someone starts to feel those emotions for the past?
Yeah, I do see that from time to time, as you can imagine, particularly with middle-aged adult clients, more so than younger people. Just as adults, we see the time go by so quickly. It's almost Friday, I like to say. It seems like, it's almost Friday again. But yeah, certainly addressing that in treatment. I try to stay away from what sounds just like an inflated pep talk, because I don't think anybody likes to really be talked to in that way. But that's essentially what it is. Let's not reflect on the time lost, but really what time you have gained and what time you can still gain by not allowing these compulsions to take over your life. I don't think there's any harm in looking back on the things that we wish we would have done or could have done differently, but let's just use that information to apply it to the future in terms of how we want to live life now, rather than kind of going down the rabbit hole of the past, if you will. Yeah,
absolutely. It's almost that kind of acceptance of it's done, can't change it. What we can change is the future.
Absolutely. Well said. Okay. And I think that's, some patients are responsive to that, and then others, it's a little trickier to get them to see. Yeah. And especially depending on how long they've struggled. That's true. It's different if it's been a year in comparison to somebody that has struggled for 30, 35, 40 years. That's a lot of time that they feel like they've lost, obviously.
Yeah, absolutely. Yeah, I guess there's work to be done there to kind of give it time and work through those emotions and naturally come to a place of healing, I guess.
Yeah, absolutely.
Yeah. Okay. And I noticed on your website you say for some clients you bring in acceptance commitment therapy. What would be the scenarios in which you'd bring that in?
I would say that I probably need to change my website, because for the majority of adult clients, I bring that in pretty consistently now. Not so much with adolescent and younger. Not to say it can't be effective, but just in my experience, it's been harder to really implement the basic tenets of ACT. But I absolutely love the integration of ACT and ERP for the vast majority of adult clients. There are some that I'll, kind of stray away from a little bit, from time to time. Patients, not to stereotype anybody, but particularly older males can find ACT to be a little hokey or a little too new agey.
Yeah.
And I still try to push it with them, but obviously, the patient has the end right to say what type of treatment they want. And some people are just very hardcore ERP, and that's okay as long as they're seeing results.
Yeah. No, I get that. I can see why they may. I'm a fan of ACT, but I can see why they would see it that way.
Yeah. I get a lot of eye rolls. Let's just say that from time to time. No matter how much I explain, the evidence base behind it, to some it still sounds like we're just alming our way to peace or something like that.
Yeah, absolutely. And is it like the metaphor side of ACT you bring in a lot?
Yeah, I bring in the metaphors a lot. I explain to the majority of adult patients my view of the difference between an ACT-based exposure or a value-oriented exposure versus a purely ERP-based exposure, and give them some examples around that. And I think it can help sort of stir up their motivation for change when they realize that not only is doing this exposure, moving me forward in treatment, but it's also adding context and value to my life.
Yeah, no, absolutely. And for the listeners, because I know I'll get questions if I don't ask it, can you give an example of, say, the stereotypical ERP exposure versus an ACT-based exposure?
Yeah, of course. So I'll use, kind of classic contamination as an example, just because I feel like it's the most media focused at times, fortunately or unfortunately, whichever way you look at it. So an ERP-based exposure, let's just say we're going to go in a public bathroom, use the bathroom as you normally would need to, touch everything as you're instructed, and then, not wash your hands as you leave, actually grab the handle, etc. Some could argue that could add some value, but at the end of the day, it's just doing exposure for the sake of an exposure. Perhaps we're going to add in, touching the toilet seat while we're in there. Who knows what can happen? And a value-oriented exposure, my favorite example is, I'm a mom, so I always have mom examples, but really pushing a mom to finally sign up for the field trip, and they're going to the zoo and the zoo is nasty and contaminated, and we're going to find ways to touch guardrails and really interact with the kids and the animals, which I have a specific patient in mind that we did this with, but to really kind of dig in to the exposure, but at the same time, wow, you're on a field trip with your daughter that you have otherwise been avoiding. So what an awesome value-oriented exposure that is.
So that's a good example. It's kind of tying in the exposures to people's goals, to their values, to what they want to achieve in life or do in life. Is that a fair way to say it?
Yeah, no, that's a perfectly fair way to say it. Yeah. Okay. And I think in that example, that, like I said, I have a particular patient in mind, her being able to recognize, like, okay, this is what exposures can look like, I think really helped her, because she was just envisioning herself, being put in these quote unquote terrible, grueling, gross, disgusting situations day after day for treatment. But she realized, it's not only it's a time saver as well, because she's incorporating these exposures into all these value-oriented things that, how she wants to live life.
Yeah, that's a good point. And it's obviously far more motivating, the second scenario, than the first, because it's not just doing something for the sake of it or recovery, it's doing it because it aligns with everything she is.
Yep.
Yeah, I can absolutely see that. Okay, and actually, something I don't often ask therapists when we talk about ACT is the values part. And the ideas of values don't have to be intertwined with ACT. You can just take it as it is for those that don't want to. Do you work with people to how do you work with people to kind of dig out their values, their core key values? Are there any kind of set exercises you do?
Yeah, at the beginning of treatment, if I foresee somebody to be sort of a good candidate for ERP, combined with ACT, we do a variety of activities that can bring out, what somebody ultimately values. My favorite, and it's sort of paraphrased for my practice, it's not the one, maybe endorsed by the hardcore ACT people, but, just envisioning yourself at a later date birthday, 97, 98, whatever it is. And all these people, will pretend that nobody dies, obviously, all these people are there celebrating you. What toasts do you want to hear from people? So what kind of parent are you? What kind of employer? What kind of career did you have? What aunt, uncle, brother, sister, all those roles that we play in life. How did you contribute to your community? If you have a faith, how did you contribute to that? So that can really pull out a lot of good information when it comes to helping somebody recognize their core values. I think when people hear it at first, it again, perhaps maybe sounds a little hokey. They think like, oh, gee golly, I want to be a good person. And they think it's more about that. But when you dig a little deeper, most people can really begin to identify with those concepts and themes.
Yeah. No, I agree how it can sound hokey. But I mean, I haven't done that. I think that's a great exercise. I've done something similar in the past. And it's unbelievably powerful when you give it a few minutes and really think. You can almost get quite emotional hearing these people in your head kind of saying all the good things you've done and who you were.
Yeah, that typically draws up a lot of emotion. I would say that usually is a session with a lot of tears for most people.
Yeah.
And sometimes me included. Sometimes I'll get a little teary hearing somebody speak to their values and how they want to live their life.
Absolutely. Yeah, no, I love that. Okay, so you work with people with insomnia or who are affected by insomnia. I guess we can touch on that, but also just generally, what kind of some of your tips around getting better sleep? Because as far as I'm aware, poor sleep, any kind of disorder, but also OCD, that it affects that. So, yeah, what would you tell someone who's just not necessarily they don't have insomnia, but they're just currently not getting good enough sleep?
Sure. I would say just first and foremost, in the age of technology, kind of having a technology in the bedroom fast and no longer incorporating that into your daily or your nightly routine. I think so many of us fall asleep with some sort of electronic device in our face. Yeah. And I think if you can find another method to kind of introducing sleep and the fact that you're going to bed, whether that's reading a regular book or meditating or whatever you like to do, that's always a good step. Another general suggestion that has been passed along to me that I continue to pass along to clients is that let the bedroom only be for sleep and sex. Quite frankly, it's not a place to do your work and balance your finances and have these really rough conversations. Like, let's just reserve it for this special space. And then ideally the body can, respond to that. And it knows, this is the place I go to bed, and some of those behavioral cues are set in.
Yeah, so as soon as you kind of get in bed or get in that room, your brain is already kind of tricking yourself into thinking now you need to be going to sleep, and it's releasing the various hormones.
Exactly. Yeah. And not to give a gross example, but it's similar to, if you kind of have to go to the bathroom, the minute you actually get there, you really have to go with urgency. It's your body's response to these external cues is the way that I explain it. Yeah. I explain it to patients. So the same thing can happen with sleep. It's not quite as dramatic. Obviously, you're not going to walk in your bedroom and pass out, but some of those same things internally, physiologically can happen.
Yeah, absolutely. Yeah, I love that. And I'm curious, with insomnia, what is the CBT treatment for that? What does that look like?
It is a fairly short-term evidence-based approach that is a fairly manualized protocol that is certainly individually tailored to each person. Yeah. I don't often see patients that come to me solely for insomnia. It's usually co-occurring typically with OCD or another anxiety disorder. That's not to say I won't or refuse, but that's typically not the way people get to me. It first starts out with evidence-based measures, just like everything else, to kind of see where they're at with regards to their insomnia. It starts with basic psych education for them to understand how insomnia is reinforced, behaviorally. And then from that, it's a step-by-step approach to equipping them with some fairly basic but sleep-specific CBT skills, working on sleep hygiene in general, which kind of focuses back to some of the general suggestions we just chatted about.
Yeah. Okay. No, thank you. And that with insomnia, and this is purely my curiosity now.
Sure.
It's not one of my pre-built questions.
Yeah.
How much is insomnia kind of? I've never had insomnia, but I can imagine if I had it, I would see it as it's something that's happening to me, not as something I'm doing. And what I mean by that is, I guess, how much is it? It's kind of an issue with the brain versus there's actually maybe years of bad habits that have now led to this real bad sleep pattern.
Mm-hmm. So it's I certainly think it's a combination of both, but I think most people that I see come to it with that kind of perspective in mind, like it's something that's happening to me. There's nothing in the world I could possibly be doing that's causing this. So that's when we begin to suss out what does their sleep routine look like, specifically what's sort of the internal dialogue that they have about sleep. Are they constantly checking the clock when they notice it's 3 hours after the time they were supposed to fall asleep? Are they already catastrophizing the next day? I'm going to be tired. I'm going to perform poorly in the meeting, and so on. So a lot of those, internal processes are deeply ingrained. So the goal is to kind of rewind a lot of that through awareness, and then obviously other skills and strategies.
Yeah, no, that makes sense. And I can imagine if it's linked with OCD as well, as symptoms start to reduce in OCD, I can imagine insomnia decreasing as well.
Absolutely. Yeah. So even though if some people come to see me and say, like, here's the two things I want to work on, OCD and insomnia, even if they place them both with the same importance, I say, let's, if it's okay with you, let's focus on the OCD and see how much improvement you can have with the insomnia. And because chances are by the time they're in a good place with their OCD symptoms and even ready and willing to discuss and work on the insomnia, the symptoms of the insomnia itself have decreased so much, and they are getting better quality of sleep, that the work around insomnia that needs to be done at that point is fairly minimal. That's obviously not for everybody. People, can certainly still have pretty wicked insomnia after OCD symptoms have been resolved. But in my experience, that's kind of been the trajectory. Yeah,
cool. No, thank you. That's interesting for me. Insomnia is not something I've thankfully had to deal with. But it's good to share that information with the listeners. Okay, so I guess what advice do you have for anyone listening who wants to be able to tolerate uncertainty more?
Ooh, good question. I think it would I think a good first step is to go back to recognizing your values. I don't think you have to have a therapist to begin to start recognizing your values and tapping into that. And then slowly but surely kind of attacking or approaching those things that you do value, but perhaps you've been avoiding because of the general uncertainty that they bring. So I have a patient, name unknown, of course, that desperately wants to go see her grandparents in a foreign country. I won't even name the country to protect her privacy. But there's so much uncertainty just around the trip as a whole. Not even that directly relates to her OCD symptoms and themes, but just, she doesn't tolerate uncertainty well. She's never taken an international flight, those types of things. But now we're working on it from that perspective, like, wouldn't it be so valuable, not only to you, but to how that would be for your relatives as well, to be able to see you, and can you accept the uncertainty that comes with that? And that's a big step. Obviously, that's a huge trip or whatnot. So there's things that we can do to help her get there, leading up to it per se. Yeah. But in general, I feel like most people are motivated to accept uncertainty more if it does tie in to their values.
Yeah, it makes a lot of sense. It's kind of like tipping the scales in favor of making it worthwhile to kind of live with that uncomfortableness.
Yeah, absolutely. Like going back to the example with the mom and the petting zoo or whatnot, there's so much uncertainty there. But I think, if you're looking at an uncertainty versus value scale, like you said, the values is it's higher there. So she's willing to accept the uncertainty because it does contribute to the values so much.
Yeah. No, that makes a lot of sense. And how has your view of treatment, if it has changed over, say, the last 3 to 5 years?
I would say just in short, habituation versus tolerance of uncertainty is probably the biggest shift for me, and then obviously in just the OCD therapist community as a whole. I really prefer the tolerance of uncertainty, or increasing your tolerance of the anxiety, versus the belief that let's just stay in this exposure for the next 49 years until your anxiety gets down to a 1.
Yeah.
You know, it seems so unpractical. And I feel like a lot of patients get really discouraged when they feel like that's the goal. Like, how long am I going to have to be in this state if the expectation is that, poof, I'm not going to have anxiety when I come in contact with this feared stimuli? So either increasing the tolerance of or accepting uncertainty is really my preference in terms of how I construct exposures and ERP as a whole.
Yeah, that's interesting. Yeah, I mean, I've asked that question a few times now to various therapists in recent months, and they've all kind of talked about habituation, and they still use it, but they're somewhat moving away from the idea of it. And yeah, I like the way you described it there about increasing your acceptance of uncertainty.
Mm-hmm.
Yeah.
Absolutely.
You have control over that, right? Whereas habituation, you're hoping your brain is going to learn as a
Absolutely. And that can kind of be a double-edged sword, as you can imagine, because if you're sitting in that exposure thinking, okay, my anxiety has to go down, you know, if anything, it could spike back up.
Yeah.
It's just really, I think it's really hard for a patient to endure that. And, you know, from time to time, I will see people that have kind of done their own self-study before they get to me, which is great. And they are very much convinced that habituation is the only way to go. So I try to, you know, certainly respect that and modify the best way I can, while at the same time showing them that there's a lot of value in other ways to look at treatment.
Yeah, no, excellent. So blanking here. What have you noticed about your clients who seem to recover much quicker than some of the others?
Oh goodness, I would say I guess probably most therapists answer this way, but their efforts in between sessions. You know, it's not just about showing up to the weekly session and giving 100% effort there, but it's also about the diligence that you put into treatment in between sessions as well. And again, that goes back to where it places in your priority list. You know, if it is a reasonably high 3, 4, or 5, then you're obviously going to put the intended amount of work into it, where if it's 12, 13, 14, that's probably not going to happen, unfortunately.
Yeah, no, absolutely. And I think even if people have said that before, I think that's something that needs to be drummed home. Because, yeah, like you said, what you put in, you get out usually. And we want to see people putting in more effort between sessions, because it's going to help them, right?
Yeah, absolutely.
Yeah. It was kind of like you hated it when your teachers at school told you to do the homework, but there was a reason why they were saying that.
So true, absolutely.
And I never did my homework, so.
Oh, me neither, Stu. We're in the same boat there. I never did. I'm surprised I'm at this place in life after my lack of homework doing.
Well, exactly. I mean, I struggled in school, so like I kind of see why now. If I'd done my homework, maybe I wouldn't have struggled.
Yeah, practice makes perfect,
exactly. Right? Okay, so let's say someone comes up to you, they know who you are, and they have OCD, and they just want one bit of advice. What do you tell them?
Live life according to your values. Push past the uncertainty.
Nice. Yeah, love it. And so this question's a bit more personal. So
sure.
I'm all about, obviously, self-care is a theme that's come up on this podcast a few times in recent months. And it's something I want to drum home more, because it's something people can do whether they have a therapist or not. It's something they can do if they have a therapist as well. And I think it's important to get that holistic view. So I guess what are some of your, as an individual, what are some of your self-care habits or rituals that you do that really kind of nourish your soul?
Absolutely. Exercise. It's probably number one. I'm a big runner, outdoor enthusiast. So I guess that goes into number 2, like being in nature. Just got back from a big backpacking trip this weekend with my family. There's nothing like being in the woods with no access to technology whatsoever. You can't get a text, you can't get an email. It's a beautiful, beautiful thing. So I I love that. And I would say just time to myself, as a therapist, which I love, obviously, but addressing other people's kind of needs all day and talking and chatting. And by nature, I'm an introvert. So when I get that 30-ish, maybe minutes to myself without a patient or a husband or kids, I really, really cherish that.
Yeah, awesome. No, I love that. And what is it about being in nature, other than obviously the disconnection from the internet and technology, which I completely agree with, although it's a bit weird the first sort of 30 minutes, but then you get used to it.
Right.
What else is it about kind of being in nature that I guess you like so much?
I would say, especially being here in Colorado, where it is so beautiful, just kind of soaking in the scenery. I love photography, so I love to kind of incorporate that as well. Not that I'm constantly in therapist mode, but I actually kind of do some grounding techniques with myself and see what I can see, hear what I can hear, kind of taking it all in.
Nice. Yeah. Okay.
It's almost like meditation via nature.
Yeah, no, I love it. And Colorado is a beautiful place to be in nature.
Absolutely. Yeah. Living a kind of 24/7 vacation in terms of scenery and looking out the window, seeing the mountains and trees. It's lovely.
Yeah, absolutely. I'm usually unbelievably happy to get home, whether that's home or home to my country. But yeah, when I left Colorado, I was sad to leave.
Yeah,
It's kind of, wherever you look, there's mountains everywhere. It's beautiful.
It is beautiful.
Okay, so if you could pick up the phone and call your 20-year-old self, what would you tell them?
Ooh, 20-year-old self. Keep doing what you're doing. Yeah. I don't really believe in a lot of regrets. I feel like we all kind of have a path.
Yeah.
And when I was 20, early 20s, I was spending a lot of time in East Africa. And like I mentioned earlier, that kind of got me the trajectory of sitting in front of you here today. So nice. I would tell myself, just keep on keeping on.
Yeah, no, good advice. And whereabouts in East Africa was it?
Kenya and Tanzania, more so in Kenya.
Yeah, nice, beautiful. Okay, so you've got a billboard in Colorado. What do you want on that billboard to say?
Oh, gosh. Oh, am I trying to market my practice, or what am I going for?
Let's say you can't promote your practice. That's
okay. Can't promote oh gosh. Accept the uncertainty. That doesn't necessarily promote my practice, but I guess maybe backhandedly it does.
But you're at the bottom.
Yeah, right. Yeah, I would say accept the uncertainty. Yeah. OCD or not, I think tolerating uncertainty is so difficult for the vast majority of the population. Yeah. It's very rare that I meet somebody that's like, yeah, just can totally take it as it comes, don't care about structure or planning or any type of certainty. So I think that the more we can tolerate not having that certainty, the better.
Yeah, absolutely. I agree. And is there anything else that I haven't asked you that you wish you could have shared today?
No, I think we covered everything.
Yeah, we covered a lot of ground.
Everything that comes to mind anyways. I'm sure we'll hang up the call and I'll have a laundry list of things I wanted to tell you or chat with you about. But for now, that's all that comes to mind.
Oh, good. Yeah, we'll save it for round 2. But yeah, no, thank you. I appreciate your time today and sharing everything you've done.
Yeah, it's been my pleasure, Stu.
So there you have it. I hope you enjoyed my conversation with Ashley. And quick disclaimer, guys, this podcast is not therapy, it is not replacement therapy. Please seek treatment from a trained professional. And until we speak, take care.